And how's Institute of Vascular and Endovascular Sciences has been the pioneer in this space?
Absolutely.
How have you got your experience over last decades?
We are one of the largest volume centers in the country today. Almost of the patients that we are doing right now, almost about 60% of the patients that we do are diabetic patients.
What are the red flags for urgent referral?
Is severe rest pain. Rest pain is you can't sleep in the night because of the severe excruciating pain that you have. You have fever. There is bones exposed, or there are maggots. Maggots are basically those little worms which get into the wounds. I think these are the common things I would say which should alarm you that we need to rush the patient to the good center so that we get them treated. नया जूता पहना था, शादी में चले गए, छाला पड़ गया. And they come after a week कि जी अब तो छाला होके पूरा पैर काला पड़ गया है, सूज गया है, लाल हो गया है बिल्कुल.
Now I think a lot of companies are now working on various kinds of materials and all which are there, which will help in advanced healing of the wound.
What should every doctor watching this change from tomorrow morning in their diabetic foot practice? Good evening, everyone. This is another podcast series. We have Dr. Varinder Bedi and Dr. Ajay Yadav, Chairperson of Institute of Vascular and Endovascular Sciences, Gangaram. Dr. Ajay Yadav is Vice Chairperson at Institute of Vascular and Endovascular Sciences. We have two stalwarts of vascular surgery with us on this podcast. And one of the topics we wanted to discuss, Diabetic Foot 2026. India's need for standard treatment guidelines. That's broadly the theme.
Yeah.
And we know that India being the diabetic capital, diabetic foot is a silent epidemic. What's happening? What's next 10 years? We all know, are we prepared for handling this large diabetic foot epidemic or the crisis? And there are global guidelines all across, but are these guidelines, when we put that in Indian context, we want to hear your expert views that what are the challenges when we look at the global guidelines versus an Indian reality.
Yeah.
That's the broader theme of today. And how do we take the current practice 5 years down the line? Is there a way to improve and better prepared for this crisis which is coming in? That's the broader theme and context.
Sure.
And sir, we'll start with you with global guidelines versus Indian reality.
Yeah. So the fact is basically that the number of diabetics is the largest. We are the diabetic capital of the world. We have probably more than 80 million diabetics in this part. And another thing which is very important in India is that the number of diabetics, when you look at the urban population and the rural population, it's a 50-50. And amongst those 50% who are there in the rural population, a lot of them are the ones who are not really detected to have diabetes, or they don't even get diagnosed till very late, till the time they are ready to lose a limb and all that. And when you look at the statistics, almost 15% of diabetics in the world are basically having a foot at risk. So there are potential people who are likely to suffer some kind of diabetic foot incidents, and if they come with that particular thing, then in that case the possibility of getting an amputation done and all is very high. And Indian problem is of a bigger magnitude because as compared to the Caucasian population, we see people who walk, a lot of people walking barefoot. And then of course the second thing is, even sometimes when you go to the temples and all these places, diabetics tend to walk on bare feet. And that is where the whole thing starts off, that if you have diabetes which is uncontrolled, then in that case all these patients tend to present with advanced diabetic wounds and all. So I think that is one major problem as compared to the Caucasian population. The incidence is definitely lower out there, despite the fact that their diet is probably much richer, but then probably we are much more prone to developing this kind of disease. And there is a geographical variation also. South India, of course, you see much more of diabetes as compared to rest of the part of India and all. I think Ajay will probably...
Absolutely, sir. I think we are the diabetic capital of the world, and the numbers are exponentially increasing. So by numbers, I would say we may be just short of China, but the way we are growing as a population and as a diabetic population, we will overtake everyone. The second part, as I was also saying, that we also have a huge number of young patients with diabetes. So in Western world, diabetics usually affect people more than 70s. In India, we are mostly in the early 40s, 50s. So you can imagine somebody losing a leg at that age. So we are in 40s and 50s, you're not even retired, you're at prime work. That's the earning capacity. So imagine a earning member of the family loses a leg, is an amputee, he can't go back to work. How much of the financial trouble the family will have, how much of the loss the nation will have. So those are the things that we have to look for. So it is not just diabetes are increasing, it is the kind of people that it is affecting, young people, people with young families, people who are growing, and they are the ones who are losing their legs because of diabetic foot. So I think this is a very pertinent problem that we need to treat now.
I think, yeah. And just to add on that, as we talk, every 30 seconds, there is somebody in the world who's losing a leg
Because of diabetes.
because of diabetes. So this is something which is eminently preventable. And that is what I think the Indian guidelines have to be strategized in such a way that we detect early, we diagnose early, and then we treat early so that all these complications can be prevented.
मतलब अगर आप देखें, सोचें कि इस 20 मिनट के पॉडकास्ट में 40 एम्पुटेशन हो चुके हैं. So can
That
you
is-
imagine that loss which is happening to the world? 20 मिनट में 40 amputations around the world.
And इसी पे thought है कि we all know that this is a problem and we are heading towards a crisis. Do you think that progress we are making is enough and is uh, because diabetes, the first reference point might be a clinic near your
Absolutely.
physician.
Yeah.
Is this there's a lack of standardization or understanding because in medicals graduation or studies, diabetic foot is not being
very
we are not
true.
trained
Yeah.
to deal with diabetic foot. It's a
Correct.
complex problem. So
Correct.
yeah, what's
So I think there is a significant lack of awareness amongst the general population, and everybody says कि मुझे तो नहीं होगा diabetes. You know, that is the general feeling that मैं तो बिल्कुल ठीक हूँ. They just don't look at that particular part. The second thing is when the person goes across to the hospital also, we do not have a protocol where we do certain tests as a baseline test for anybody. There's no way of anybody getting a medical done every year or 2 years or 3 years or 5 years for that matter. So that is the reason why these patients are detected only and only when they have a situation. Whether they get admitted with high blood sugar or whether they get admitted with low sugar and all these things, and these are the kind of complications which happen, then the patient is detected. So by the time the patient is detected, he is already in an advanced state. So I think that is something which is very important, that we need to get awareness amongst the general population. What you're saying is absolutely spot on, that we need to have more structured focus on diabetic foot problems and all, and what is the magnitude of the problem. I think
Sir, absolutely. Now, if you look at it, like a person who suspects cancer will get a PET scan done. Patient who suspects cardiac problem will get an ECG done or an echo done. Patient who has diabetes will get sugar testing done. But very few people know what test to be done for diabetic foot. Now, they do not even know which doctor to approach for a diabetic foot problems. Or they'll go to probably a general surgeon, or they will go to a orthopedician, or maybe a plastic surgeon, or even a normal physician who may not be able to diagnose diabetic foot or the vascular issues associated with diabetic foot, which in the end will, and that's what sir was saying, that these are the things which delay patients coming to a proper place. And because they're coming late, they tend to have much worse disease. Their foot is already gangrenous, or they have lost some toes, or they have a foot which is imminently going for amputation. These were all preventable a few days or a few weeks back. So if they were diagnosed early, they could have been treated early, and they could have gone back to their normal life.
See, another thing which is very important in diabetic patients is, unlike the normal people who are there, you have a small injury, a scratch also on your leg or hand. You immediately start getting pain, you get signs of inflammation, you'll go to a doctor के देखो infection तो नहीं हो गया है. In diabetic patients, the systemic response is absolutely muted. So patients come to us with wounds with maggots at times because they can't feel a thing because of the neuropathy which is there. They are not able to feel a thing, and he'll come to you with a wound which is all gone, badly infected, badly mottled and all that kind of thing. And yet the patient says, I'm perfectly fine. So it's a major challenge because these patients are the ones who are critical in terms of they are like the ones who are likely to have an amputation because of that reason. Because the manifestation which is there in a normal person is not there. So they don't really get any feeling. You may not get a high grade fever, you may not get anything. Suddenly you do a blood count and suddenly you find that the counts are 25,000, 30,000 and you're in gross sepsis. That means there's an infection which is spread throughout your body. So that is the major difference between a normal person and a diabetic patient.
The response is absolutely muted.
True.
And I'm just going back to this point where we said global guidelines here to be simplified. And one of the points, as you said, that if you have a chest pain, people clearly know that ECG needs to be done. Like if you have something related to foot and you're a diabetic, what is that test is not that clearly
Correct.
articulated
Yeah.
or not that being taught. So complex things come later, but this is a simplified message which can be
Correct.
communicated to a lot of people who are the first touch points for diabetic patients.
absolutely.
What is that test? If
I-
I may ask the
So I think I'll start with a very basic test is please get your foot examined every time you go to a doctor. True. तो आप जब भी डॉक्टर के पास जाएं अपने जूते सॉक्स उतार के उनको बोले मेरे पैर देख लीजिए आप, खासकर अगर आप डायबिटिक पेशेंट हैं तो सबसे पहले क्या प्रॉब्लम आती है कि आपके पैर की पल्सेस देखनी है कि खून की नब्ज आ रही है कि नहीं, कि पैरों में आपने देखा कि नब्ज आ रही है। दूसरी चीज जो देखनी है कि आपके कोई जख्म तो नहीं बना है, क्योंकि कोई जख्म बन रहा है, कोई छाला बन रहा है, कोई वहाँ पे नाखून कट गया है, ब्लीडिंग हो रही है, पस आ रहा है, पानी आ रहा है, ये सब चेक कराना बहुत जरूरी है। नॉर्मली क्या होता है क्योंकि आपके पैर सुन्न हो जाते हैं डायबिटीज में, आपको पता नहीं चलता है, तो आप नेग्लेक्ट करते रहते हो। जब तक आप किसी घर वालों को नहीं दिखाओगे या बाहर डॉक्टर को नहीं दिखाओगे, आपको पता ही नहीं चलना कि उसमें दर्द है कि नहीं। सो आई थिंक सर विल ऑल्सो एग्री कि अगर आपको कोई जूता काटता है नॉर्मल आदमी, तो अगले दिन वो जूता नहीं पहनता क्योंकि दर्द होगा, चुभेगा। डायबिटिक पेशेंट वही जूता 4 दिन 10 दिन पहनेगा जब तक वो जख्म नासूर ना बन जाए। और जब तक वो पहुंचता है तब तक वो इन्फेक्शन हो जाता है, कीड़े पड़ जाते हैं, सड़ जाता है। And I think this is something which is very important for patients. That whenever you visit a doctor, tell them to see their feet.
So
I think that's the single easiest test or the cheapest test they can get done.
I think that is what the Ajay is saying is to just summarize. It's the clinical evaluation which is the most important part. You don't need any hi-fi tests and all that sort of thing to assess the patient for a diabetic foot. It is just looking at the patient feet, checking the temperature, looking at if there are calluses and all forming out there, there are pressure points which are forming, poor footwear, all these things, cracks, corns. These are one of the ones which are pathognomic, of an early diabetic foot. So probably these are the patients you should keep them on a watch list, that you must tell them that, okay, you must come and follow up every 2 months, 3 months and all, and see that, you take care of your feet and all. So there is a saying in South also that you do what is called Padukam Puja. Like we worship our gods, the same way we need to worship our feet because they are the ones who are going to keep you going.
Absolutely.
So you need to basically look after your feet, treat them like a god, that we do puja every day, we put all, milk and everything, we do all that chadava. Same thing you need to do for your feet. So that is something which is very important.
and if global guidelines are very very structured, clearly that this part offloading, infection, all those
Yes.
are clear.
Yeah.
But if you have to put those structured guidelines in Indian context, what would be the areas where things would be different in Indian context? First question is, will there things will different, not different, just because of infrastructure and the magnitude of the problem?
Yeah.
What's your view of those?
So ideally, a diabetic patient should undergo a full foot examination every year. Every 2 years, he should get a ABPI. ABPI is ankle brachial pressure index, which is a very simple test to check for the pressures of the arteries in both legs and arms. So those are the two simplest tests I would say is mandatory for all diabetic patients. Once they cross the age of 40, should start getting these tests, and after 50, we should get them very systematically done, right? Then there is nerve test. So it is called a monofilament test. It's a very simple test. Doesn't cost any, doesn't have a money attached to it actually, and can easily be done in each and every clinic. So it's a monofilament test. Then there's a tuning fork test. Then there is a temperature gauging, biothesiometer. So these are things which are there in 95% of all diabetic foot care centers. You will have these tests done. And if you can get these tests done on a yearly basis, or at least bi-yearly or every 2 years, you would know that yes, your feet are in general safe. Sir?
True,
Any
true,
other,
absolutely.
no need
I
for
think
advanced tests
you
like
don't
CT
need anything
scan or
advanced.
MRIs or things.
Like
Those
I
are
said,
last.
number one thing is awareness, and even when the physician also or the surgeon also has a look, he should do a proper evaluation. And the only thing which happens is that sometimes in small areas and all, the doctors don't really have time. They're rushing through patients and all. Volumes are too many, and they don't really look at that till the time. So I think what we need to do is improve the healthcare system first, because unless and until you're able to reach to the last mile, you're able to reach the last person out here. Like I said, 50% of the patients are in rural areas. Unfortunately, our the presence in those rural areas is very, very limited. A patient from a village will go to the hospital or a clinic and all that, PHC clinic and all, only and only if he's got a problem. So I think what we need to work is first of improving the basic infrastructure, bringing about awareness amongst the population as well as the physicians, and then of course work on the next level. Because unless and until we catch them at the basic level and all, whatever things we do, it'll all be inadequate. Patients will still continue to come late to you, because coming across from a small village or a town to a major city and all that is a challenge. And nobody wants to travel so much and all unless and until there's really something which is life threatening, not even limb threatening. So Indians by nature, they are very compromising. They have some blocks in the arteries. So initially he was walking 2 kilometers. So suddenly he find कि वो 1.5 किलोमीटर के बाद में टांगे दुखनी शुरू हो जाती हैं. He'll say कि चलो ठीक है 1.5 किलोमीटर ही चलूँगा. Gradually you find patients coming to us, complete blockade, not even able to walk 10 steps. Then he will come across कि डॉक्टर साहब अब देखो क्या हो गया. So I think that is another thing that we need to bring about.
And any example of any other disease segment where you feel that things have gone well, the awareness level, the complications and everything, and these are the examples which can also be
I think
looked at it from a diabetic foot
the best thing is the heart.
heart.
Everybody is one thing which everybody is morbidly scared is of a coronary artery disease. That suddenly कुछ chest pain हो जाएगा, you call it, heart attack हो गया. Whereas the same thing we call it the leg attack and all, which is there. People don't bother. ठीक है, पैर है, ठीक है, कुछ नहीं है, ठीक हो जाएगा. Heart they know is fundamentally something which if it doesn't tick, you're gone.
So FCT
So I think
अभी वो register नहीं किया है. तो
it has not.
It will not happen to me.
Correct.
This is somebody else's problem. It's
Yeah,
not, that's
yeah.
not,
It will not happen to me.
Yeah. See, but another thing which is there is we have a very, robust diabetic foot care center. So where we do all the dressings and wound management, Dr. Ajay sits out there. So every time you see patients along with the relatives coming out there, half of them they come across to the consulting room and say, Doctor साहब मेरा भी check कर लो, मुझे तो नहीं कुछ हो रहा. Yeah, the son will say or the grandson will say कि मेरा check कर लो, मुझे diabetes, father-in-law का father को diabetes है, आप please मेरा भी देख लो, मेरे पैर तो नहीं हो रहे. So this is, indirectly they are at least becoming conscious of the fact if my father or grandfather is suffering from this problem, he's come up to this stage, then the awareness kicks in. And that person will basically, see if somebody else in the neighborhood, anybody, friends, family and all is there, who's got a similar problem, he'll say कि भाई जाके दिखाओ. So this is something that we are seeing now happening, because the relatives and all, when they come, they realize what is the problem. Even a problem with a different problem, person will come across and say कि डॉक्टर साहब gangrene तो नहीं हो रहा है. So gradually the awareness is increasing, but that is because of your direct contact with the patient.
so stakeholder meetings maybe across the region, across the community. You're
Yeah.
creating some standard, easy to consume framework.
Yeah.
It is a
It's a,
step which can help.
Absolutely.
And I'm moving to another section where, when do you think diabetic foot ulcer becomes a vascular referral?
I think from the very starting.
Yeah.
I would say, I think the first two examinations for any diabetic patient, diabetic foot patient, is one, does he have normal pulses or not? So the vascular examination is the first thing that you do. Because if the patient doesn't have vascular pulses or the peripheral pulses, then it's an emergency. So he'll have to get some kind of blood supply increase procedure so that the wound starts healing. So that is number one. Number two is, what is the sensation? So what is the neural part of it? Because diabetic foot will always become worse in two cases. One, if there is no vascularity, another, if there is no nerve supply to that area, or we say if it's a neurogenic foot or not. Because if it's a neurogenic foot, he'll keep coming back with recurrent ulcers. But if it is a vascular issue, he'll immediately go into gangrene and will lose the leg. And usually the pain is very bad when they have it. Sir?
But it's, I think once that one is the pain part, and then gradually it degenerates to such an extent that the foot becomes insensate, as we call it. So there's no sensation. So many a time when we are doing this cleaning or debridement, as we call of the wounds and all, the patient doesn't feel anything at all. You're cutting and the relatives are watching in awe. Because they realize कि डॉक्टर साहब आपने कोई local भी नहीं दिया इनको pain नहीं हो रहा है. And the fact is that they've come up to that particular stage where the neuropathy is so overwhelming that the nerves have become completely dead. And you can literally chop the patient and all, cut the foot and everything and all, and nothing there. The patient will not even wince at all. So I think that is the most dangerous phase which is there and all. Because once that patient comes up to that particular level, then the chances of major amputations and all goes up, because this patient, he is going across walking barefoot anywhere and all, he is not feeling any stones, he is not feeling any pebbles and all. So he will have some trivial trauma and then it will just go on increasing and all.
One of the things, I mean, just building on what you said, I've done some cross specialty CMEs, moderated those specialties, and when a vascular surgeon is presenting what things they do,
Yeah.
I see a lot of excitement and among the general physicians, because general impression and
Yeah.
your actual is that that's kind of, there's a gap in that. So for
Yeah.
example, simple things like I've seen questions coming on those cross specialty seminars is that how do I measure ADPI, right? I mean, physical examination, what infrastructure, color Doppler, do we have that, not have that?
Correct.
So I think vascular referral would
Yeah.
start when they measure that vascularity is
Yeah.
compromised, objectively document.
Yeah.
So how do you solve for those things? I mean, just I'm saying just building that cross specialty reference,
Yeah.
given the number of vascular surgeons are, they are super
Limited.
specialty limited.
Yeah.
The larger audience or the larger specialists who are dealing are general physicians, general surgeons. So how do we build that piece?
Yeah.
So fortunately, it's a multidisciplinary team that we have here. So we have a plastic surgeon, we have a dedicated podiatrist, we have diabetic foot nurses with us. Of course, we are all vascular surgeons. We have a team of more than 20 people here who are looking after diabetic foot on a regular basis. But you're right, the awareness is less. And not many centers will have a full dedicated team. So there is only one surgeon, one nurse, or one podiatrist who are doing. A lot of times they're just general surgeons. A lot of times they're just MBBS doctors who are trying to do something about it. They're doing their best. I wouldn't say they're not doing, but the fact is the best results come when you have a dedicated team behind it, because it's not every surgery can be done by me. So we have a good, very nice plastic surgeon involved with us who is doing every single case with us. So there are new technologies which are coming in, VAC therapy, there are BTMs, there are specialist, I would say secondary skin dressings which are coming in. Then there's regular debridement which needs to be done. The pressure offloading, so an orthotist comes here who will give us a specialist shoes, who's going to give us a lot of good centers, especially in the south, have employed mochis,
Cobblers out there.
to do this job for them. They just make special shoes for those patients. So it's a whole system which comes together and saves feet. It's not just two vascular surgeons who are doing the work. So it's a teamwork which is happening.
Absolutely. And one more thing which happens very commonly with us, and every day probably it happens, a patient who's got a toe gangrene, seen somewhere in a small place, recommended BK amputation, below knee amputation as we call it, cutting below knee, or somebody even tells them above knee. And when you see the patient and all, you say that, okay, this foot is eminently salvageable. This is, even if there's a blockage and all that in the artery and all, 15 years or 20 years back, we didn't really have the technology to treat these kind of small vessels in the below knee segment as we call it. Today, we are doing pioneering work across many centers, of course, in India, where you're able to open up, and the main purpose is that you should be able to get the foot, only the minimum minor amputation should be done, and you are able to salvage the foot. So today, I think our average success rate, I would say, for doing a salvage of the foot, a patient who comes to you with forefoot gangrene also would be almost about 95 to 98%, which is remarkable. But this patient goes to the wrong place and all that sort of thing, there's a 100% chance that he will land up with a below-knee amputation. I think, Ajay?
Absolutely, sir. I think the success, especially in our hospital and our teamwork, is because we try and encourage patients to get treated early. That is one. So we work together. So if there's a complex case, there are 4 or 5 people, surgeons working together to make it better. Then we have a dedicated plastic surgeon with us. We have nurses with us. We are offloading people with us. So everybody is doing their bit to help the patient. And as sir said, doing an angioplasty, below the knee angioplasty or the BTK angioplasty with the new devices that we have a atherectomy with us, we have laser with us, we have dedicated balloon, coated balloons, stents. Now, all this technology help in opening up the arteries to the toes where the blood supply is needed to keep it open also for a long period of time, and we can heal the wound. And I think it's the technology, the personnel, the doctors, the nurses, the patient's relatives, all of us come together to save that foot. And I think that's a beautiful system that we are looking forward to.
And how's Institute of Vascular and Endovascular Sciences has been the pioneer in this space?
Absolutely.
How was your experience over the last
Yeah.
decades? I think.
Yeah, I think that's what the thing is that we've built up, and today we are one of the largest centers this part of the world, I would say. Practically in Southeast Asia, you will not find anywhere where the number of consultants that we have, the advanced facilities that we have out here. 2 hybrid cath labs.
Then when will you start, sir? Which year? This was the first.
The cath lab and all. I think our first cath lab,
99
dedicated cath lab
Catholic came between 1999
the
to
center
2000,
started in 2000, 1999. Yeah.
where we got our first independent vascular cath labs. So we were doing cath labs in a different setup because, of course, the technology was not as great.
Yeah.
But a full DSA hybrid cath lab was first given to us in 2001, 1999, 2000, and that's the time. So it's been good 26, 27 years.
So I think we are the only center in this part. In fact, most of the centers anywhere in Southeast Asia will not have dedicated hybrid cath lab purely for vascular surgeons. Generally, they have small cath labs and all, which can, where the cardiologist comes and does his cardiac part also, somebody neuro will come and do his part. But 2 dedicated cath labs, which are hybrid ORs, which are there, which are, capable of doing everything. Any endovascular procedure can be done out here in these cath labs.
This is state of the.
So that is what the thing is. I think the institution has invested in our department. So that is where we are, that we are one of the largest volume centers in the country today. So I think, and we see, I think, almost of the patients that we are doing right now, almost about 60% of the patients that we do are diabetic patients. So you can imagine this is the magnitude and the number of cases that we do, average of about 350 to 400 cases in a month we do. And that one, I would say the diabetic patients are almost about 250 to 300. So it's a very large number of patients that we treat.
So we end up doing around 3,000 plus angioplasties for diabetic patients. And that's a huge number. And mind you, we are just maybe touching 0.5 to 1% of the actual load.
Yeah, that's true.
And what are the red flags for urgent referral? I just want to kind of.
Yeah.
So I would say a patient who doesn't have blood supply in the foot has gangrene of the toes. Gangrene is when the toes become black, when there is fulminant infection. Self-infection could also mean starting with blackness, but pus and redness or the cellulitis, as we call it, where there is local infection, swelling, and which is spreading especially onto the legs. There's severe pain in the local area. Fifth, I would say, is severe rest pain. Rest pain is you can't sleep in the night because of the severe excruciating pain that you have. You have fever. There is bones exposed, or there are maggots. Maggots are basically those little worms which get into the wounds. I think these are the common things I would say which should alarm you that you need to rush the patient to the good center so that we get them treated early.
And which red flag is often missed?
Well, small ulcer or something of the sort, a small trivial ulcer, and वो doctor बोलेगा ठीक है कुछ नहीं होगा कुछ नहीं, just apply something betadine or something of the sort and leave it alone. And this is 9 out of 10 times the patient comes to us and tells us कि डॉक्टर साहब वो एक हफ्ता पहले देखा था तो बोले बिल्कुल ठीक था. You see, what we are seeing in these patients is what we call the tip of the iceberg. So the disease is probably much more than what it looks on the surface. And many a time these patients come with small ulcers. The moment you start cleaning up those ulcers, you suddenly find pus pouring right between the tissues and all that. So I think even small ulcers, trivial ulcers, should not be, underestimated. Okay, this will just settle down and all, nothing to be done and all. So I think that is what we need to do: check their diabetes, optimize their sugar, and then at the same time put them on proper antibiotics and everything and wound management. I think these three are the cornerstones of treatment for such diabetic foot ulcers. And you can, if you catch them early, you treat them early, you prevent amputation.
As you said, I think that's very critical. As you said, diabetic small ulcer will not give you time. The
Yeah.
time it will become large.
Yes.
Within a week, the foot is
Yeah.
week the foot is gone.
Yeah.
Within a week, the foot is gone, not toe. The foot is gone.
And once,
Yeah. Well, for all of us, if small
Yes.
ulcer, we are busy with some work, we don't refer, we don't go.
correct.
Is that it will become so.
Yes.
Yes, that is there. So
And
that
we
is the main thing.
And unfortunately, we see it so often every day.
Yeah.
कि नाखून काटा था पिछले हफ्ते, थोड़ी स्किन कट गई.
Yeah.
या नया जूता पहना था, शादी में चले गए, छाला पड़ गया.
I
क्या
think
हुआ, मैंने घर आके सोचा ही नहीं ये तो ठीक हो जाएगा. एंड दे कम आफ्टर ए वीक कि जी अब तो छाला होके पूरा पैर काला पड़ गया है, सूज गया है, लाल हो गया है बिल्कुल.
So this is
I
a
think-
red flag which is often missed in the-
absolutely. Yes.
for a diabetic patient.
Yeah.
Even if a small
And-
ulcer,
and a-
small injury is.
And what Ajay is saying is right. Many a times, a lot of people, when they are cutting their nails and all, they use a normal blade, a shaving blade. And when you're using that blade, because you don't have any sensation, you cut a bit of the skin, and next thing is that you notice a black patch out there or tip of the toe. And that progresses into, when you have arterial disease, then you are landing up in a soup. That matter. So I think these are potential red flag. Foot care, of course, like I said, Padukam Puja. So you really need to worship your feet. Don't cut your nails, with an object which is not meant for it. And good care is something, and being aware that this could land up in a big problem, treat it in time.
And as we were discussing Amputation-free India as an initiative of Vascular Society of India. Yeah. So what has been just some light on how you have been able to create some networks with
Yes.
physicians, dermatologists.
Absolutely. So it all started a few years back, where we all together, all vascular surgeons, and under the aegis of Vascular Society of India, we started an Amputation-free India campaign. So the aim was to educate people and the physicians and the surgeons around us on the perils of diabetic foot, vascular diseases, and how we can not just prevent but also treat early. So it's a huge campaign. So we do a walkathon every year.
Every
So and it's a huge event. So it's done simultaneously in 38 cities across India. Thousands of people come and walk together with us. And these are common people, patients, doctors, nurses, all of them together trying to create awareness. So it's a huge thing that we are trying to do. And it's a very ambitious thing, that an amputation happening every 30 seconds. And as we discussed, a 20-minute podcast, we waste 40 legs. If these kind of campaigns, Amputation-free India or the Vascular Society of India together, can do something about it and can help prevent these amputations, I think it's the most beautiful thing.
And I
anybody
think
can do.
what happens right now is that a lot of money is being spent by NGOs and all in various kinds of, anti-smoking campaigns and all, talking about cancer. But probably this is a bigger problem than cancer. So we need to, get this awareness across, get some more, funding also from the NGOs and all, so that at least your message can percolate deeper into society. Because I think the first step starts with awareness. Rest everything else is, superfluous, I would say. The first thing is, if a patient feels, that he says, diabetes ka problem to nahi ho sakti hai, he goes across to a place and gets it evaluated, I think our mission is accomplished. We don't need to do anything more. None of these patients will come across to us in such an advanced state. So I think what we need to do is Amputation-free India, yes, but start with the first chapter, start with awareness. It starts with awareness. And that awareness has to be amongst the population also, amongst the physicians also, amongst all other people, for that matter.
I think there's some tipping point where this becomes a common topic among the layperson, that it becomes a conversation point.
Yes.
At this point, I think it's not a conversation point
Yes.
between the two diabetics meeting each other and saying that
Yeah.
these are the three things. They will talk about mangoes, they will talk about all other things, but they will not talk about their
Yeah.
sheep, which is
But
is a
but now that's why I said that it's always when you have some patients in the near vicinity, by knowing about their friends and family and all that, at least now we are seeing more and more people coming to you in time. So I think that is something which is a preventive checkups and all, to some extent, will help in trying to detect the disease early and treat them.
I'm moving to another piece, that one component in the continuum of care is wound care, advanced wound care. And how's that evolving in diabetic foot?
Yeah.
And one of the things which we found when we surveyed all over India, that let's say negative pressure wound therapy, the kind of penetration globally that would be there, currently it's not at there at all. I mean,
Yeah.
I've been into healthcare professional for so many years, but negative pressure was not part of my curriculum, was not part of me, it's not there. And then uh, antibiotic resistance, we are going through that antibiotic resistance. That's the load, that's a different problem. That's in diabetes, that's exponentially growing. Do we need to find some natural but physically strong products or biologics or biomaterials which can also down kind of decrease the bioburden without causing the pressure or antibiotic resistance? So just general wound care and just nuances on
Yes.
wound care, how it's going, that's the demo.
So I think if we broadly categorize our technologies which have changed, so let's go back 30 years. So in 30 years, any wound used to be just beaded in dressings and just that's it. You either amputate or you do beaded in dressing and pray to God that it heals. But that has changed. There are two technologies which have changed in last, I would say, 2 decades. One, the endovascular technology, which is basically related to increasing the blood supply to the foot. So that is basically from bypasses, which were complex and long, which are still very good. We have gone to very microscopic wires. We have gone to very nice balloons, low profile balloons. We have atherectomy devices. We have cutting balloons. We have drug coated balloons, drug coated stents, which are improving the blood supply to the foot. So the main technology was how do we get blood into the foot so that we can start saving them. So dressing alone would not save them. We have to increase the blood supply to the foot. So I think that's a huge technological advancement which has come. The skilled levels have improved. Now, these were something which were probably in Western world, we were better trained. But I think as of today, our Indian experience and Indian vascular surgeons are top of the world in the kind of work that we do, the complex cases that we do. And the second part came the local wound management. And you very rightly said, I think NPWT, which is the negative pressure wound therapy, has absolutely revolutionized the wound healing. I think that is one technology which, when started, changed the paradigm. It is not, I would say, as widely used as it should be, and probably the cost is a factor. Availability is a factor because it has certain cost attached to it. There's a machines attached to it, and they're not unlimited machines. So that is one part of it. Sir, you want to elaborate?
So I think in the last, I think, decade or so, there has been a lot of interest by the industry now because they realize the potential of the problem. So although population might not be fully aware, but I think the industry has realized the potential of having this. 15 years back, there was only one company which was having the negative pressure wound therapy. Now there are umpteen number of people who are there, special kind of dressings and all. I think these have changed, special kind of orthotic footwear which is there. Now, I think 15 years back, we didn't really have very many people who would prepare optimal footwear for you. Today, we have those kind of options and all where we need to offload a particular part of the foot and all where the wound is there. We don't want any pressure building up in that one. And thing is, you clean the wound, and now you have, negative pressure wound therapy with antibiotic implantation. That means that you have a particular bacteria growing in, you give them systemically also, and at the same time you can, inject, perfuse the local tissue with that antibiotic and clean up those wounds. And idea is basically to clean up the wounds as fast, make them granulate, cover them up, close them up, and get the patient back to walking as soon as possible. So I think one good thing which has happened in the last decade or so is the interest which has come up by the industry in terms of giving us more and more newer technologies, I would say, for that matter.
Artificial skins,
Artificial skin, dermal template and all
the
that.
templates. Again, now areas over the bones or area over the tendons or the ligaments were not easily granulating. They were difficult for even NPWT to treat. But I think that has changed.
Yeah.
Now, fortunately, as sir is saying, that the companies have started taking interest. India is becoming a market for them, and we are getting a lot of good products. And then a lot of indigenous companies, Indian companies who are making products for us.
Yeah.
So which are at a much cheaper cost, better availability, and things are changing in a very positive direction.
No, there's
So
a lot of
that's-
research which is
An
happening.
example of entrepreneurs like us
Yeah.
who work on the other part of the industry on e-commerce or
Yeah.
diagnostics, pharmacy. Uh,
Yeah.
There's a set of entrepreneurs, and just not us. It's set of
Yeah.
entrepreneurs who are finding this challenging real problems interesting, and they're saying there's a large Indian problem. Can we look at this problem from a contemporary perspective? There is AI, there is portability, there are devices. So an Indian micro needs for surgeons and doctors is a different. I think that's getting those.
Yeah. No, I think now at least we have started investing in research, which is very important. One was to bring products across from other parts of the world and apply them out here. But now I think a lot of companies are now working on various kinds of materials and all which are there, which will help in advanced healing of the wound. So I think that is something which is very, very promising, I would say.
And I think I see at least a bright future in that sense for the Indian population. That if, as you said, industry entrepreneurs, innovators start coming in, putting in their referral mental cycles and etc. Then that kind of adds value from a technology standpoint.
Sure.
I remember my first exposure to wound care was I was posted in this Bhuj earthquake.
I was there that
I
time.
was a volunteer. I was just a medical.
I was there at that time. We operated. I was in the military hospital there at that time.
I was a volunteer.
Okay,
In
yeah.
these days, and I think left, right, and center there are all kind of wounds.
Yeah. That's right.
I found that to this stage, wound carers.
Yeah, we operated on almost about 2,000 patients during that time, during the Bhuj earthquake and all. I was there from day 2 onwards. I was posted. I went from Bombay, and we were there for almost about 10, 12 days till another team came and replaced us. So we have operated in the tents out there, and what we used to find at that particular time, a lot of patients with wounds, a lot of people are putting in implants with the wounds were full of muck and all that sort of thing. And then of course we had to do a lot of good cleaning and all, because I think the main thing was to keep the wounds clean. It is not putting in various kinds of pins, screws and implants out there, but the main thing was to keep the wounds clean to some extent, so that at least they don't worsen over a period of time. Yeah.
So sir, just building on this piece, that when we said negative pressure wound therapy is one of the therapies in the wound care. Second, artificial skin or the bioscaffolds or the scaffolds.
Yeah.
And third bucket would be better delivery of the antibiotics in that space so that it stays there. Fourth would be the biomaterials in general.
Yeah, and then you can, to complete the list, you can add hyperbaric oxygen also, which is topical oxygen, hyperbaric oxygen. Yeah.
If you look at this, the technology, you're going back to nature again.
Exactly.
If you look at a philosophical piece, you're going to oxygen, you're going back to mechanical suction.
See, I think what you need to improve is the bioenvironment. That is what the wound needs basically, is that you need to clean the thing which is debris which is there and all, whatever muck is forming out there, you keep on cleaning it and create an environment for healing of the wound. I think that is something which is important. Yeah.
What do you think that in all these categories, affordability you mentioned is one of the challenges.
Yes.
What else, if you could just imagine 5 years and there's a wish list, without any constraints, there's a wish list for innovators, entrepreneurs that solve this for us. What would be that wish list without any constraints?
So I think one is obviously if we can get a great technology like NPWT at a much lower cost, that is one part of it. Second part is availability. Now, all these things are available in metro cities or the bigger cities, but percolating it down to district hospitals, now that's a very critical area because the technology is there, but making people aware at the district level or at the town level that this is there, which will help them. And if we can get the patient also aware and as well as a good podiatrist or I would say, a dresser who can help those patients use that dressings. Number three is, I would say, and it
I would
again
just add
boils down
on
to
to
awareness and
having, I think, yeah, I think
so
one more thing
using
that will
AI
add on is the
to
paramedics who are there. See,
absolutely, sir.
because you can't leave everything because everybody doesn't really have access to a vascular surgeon or even to a surgeon for that matter in smaller places. So what we need to do is improve the skill levels of our paramedics who are there, because they are the people who can provide, care at a much more primary level so if you're able to train them, somebody to apply, because today when you look at it, it is all paramedics who are doing the training. NPWT also, they are the ones who are applying. What you need to do is amplify it on a much larger scale. Go across, penetrate across into tier 2 cities, tier 3 cities and all. Then that is where it all starts off. Once you're able to penetrate into these kind of places and all, you're able to train people out there, and believe you me, this will just take 1 week for a person to be trained for this thing. He should be able to assess the wound and he'll say, okay, I can do this, I can do this, and then treat the patient and all. So I think this is something which is an important technology at an affordable cost, and probably much more research, so that what are the ways of rapidly increasing the wound healing. How sooner can you make the wound heal? Because again, infection control very, very important. Sugar control very, very important. Wound management is the most critical step which is there. Unless and until you clean up the wound and all in time, whatever you may use the best of antibiotics, you may use control the diabetes. Doctor साहब HbA1c तो 5.6 हो गया, but the wound is not improving because nobody is touching those wounds properly and all. So I think wound management is the critical step also in this one.
Just to add to this, sir, when we were looking for, one of the things we do is that find innovative technologies across the globe and bring more
Yeah.
them accessible, affordable.
Yeah.
When we talk to innovators across and just see that what is the level of evidence, scientific evidence, we found this, and we have been talking about it, but this a French scientist who is sitting in one of our towns in Viraval, working on a biofuels for last 25 years.
Really?
Imagine the level of rigor, and every
Yeah.
time he used to characterize or separate out this chytosine as a molecule, he would send it to some NMR labs in Europe to say that whether the process which he has been able to extract, was it standardized or not standardized.
Yeah.
I mean, and it was not commercialized.
Correct.
And
That is
he
what the thing is.
just
Yeah.
found that so fascinating that some 2 decades of effort a team has put in to bring some
Correct.
type of innovation.
Correct.
That innovation has a context and relevance.
See, the
So
problem,
that's the interesting piece, that there are so many pockets of innovations which can be.
I think the problem is right now, and since you are also dealing a bit with the industry, is that anybody who develops a good product wants to get a good price also for that. So I think what probably the industry also has to look at it is what are the volumes that we can generate, and then try to make it as affordable as possible. Because you increase the size of the pie, automatically, you will gain enough and all, because anybody who gets a good product or who develops a good product, like one of the companies which started NPWT in India, for that matter, or even world over and all that sort of thing, they marketed it at such a high price and all that it became eventually unaffordable for many, many patients. And today still is. So that is what we need to do, that in case we develop good technology, market it at such a price that you have a wider base of patients also. I think that's again very important.
Last section is on wound imaging. In everything we do, we measure objectively.
Yeah.
Do you think wound imaging in that sense is a lot of qualitative out there? Can AI play a significant role in that?
So I was coming to that AI today. So we have technologies, and these are evolving technologies. So of course, every year there is a new beta software which comes in. So if a patient has an app on his phone where he can click a photograph, and puts it up to an AI, a properly designed diabetic foot, a calibrated AI, diabetic foot AI, which can tell you, is it an omnious ulcer? Is it a simple ulcer? Is it a vascular ulcer? Is it neuropathic ulcer? And how soon or how emergency it is to consult a vascular surgeon or a diabetic foot specialist. And I think that's so exciting to hear. And I think we are moving towards that. It's not that we have multiple teams which are working here. We are all trying to do something in that bit too. So if we can do that, I think that's a huge help, because it gets a referral from a village in the remotest part of India to a vascular surgeon sitting in Delhi within seconds. And I think this is the future.
Yeah. So I think,
Sir, one of the questions I wanted to ask was, what should every doctor watching this change from tomorrow morning in their diabetic foot practice?
so I think the answer is quite obvious, I would say, that being aware of the problem, automatically what your eyes do not see, the mind does not, what do you call it, the slogan, which is
Register.
So that's what the thing is, that your mind has to be open, that you must realize that, okay, this patient who comes to you with a diabetic and all that, what is the kind of comprehensive examination I should do? It just takes precisely not even a minute or two to have a look at the patient. The only thing you have to do is tell the patient, open your footwear and all that, let me have a look at your foot, maximum touch, check for the sensation, and then and check the pulses. I think if you're able to do that and look for any calluses, deformities of the nails and all, and he should basically, this is some physical examination, which will in 30 seconds, 1 minute, you can come to know. And if you're aware of that, and then you know that which patient you should be segregating and then referring them to a higher center and all. I think that is something that we need to do. So each doctor, physician, whatever he is, should basically, evaluate the patient for those 30 seconds, 1 minute. And I can tell you that this will change the paradigms of treatment in India, for that matter. The number of patients who will be detected early will be phenomenal. And that will make a lot of difference, I think.
I agree. I think getting that awareness in that I'll have to examine feet of all my diabetic patients every time they walk in. So I think that is number one. Two, being aware that there is a diabetic patient with an ulcer can also have vascular issue, which will require a Doppler test. Now, it's a very easy test. You check for the pulses, you may not be able to feel it because of swelling, you may not be able to feel it because it's a very calcified artery, you may not be able to feel a pulse. But please get a Doppler test done quickly. Not wait for a month or so before you order it. Doppler test. Doppler test is a non-invasive test, takes not more than half a day to get the reports back to you. And within 3 hours, you'll have the report back with you. Then you know that the patient doesn't have blood supply, he has an ulcer which has a potential to go on to gangrene or an amputation. I should refer this patient quickly.
Yeah.
I think these two things, as sir said, awareness and checking, and two is early diagnosis and referring, is two more important things which I think the practice has to be changed.
So I think that's the take home for me. As I will summarize that for me, like any diabetic patient touch point, also take out time to observe the feet. That should become the part of the workflow.
Absolutely.
And being aware that vascular issues could be also very important component.
Yeah.
Getting a Doppler test done
Absolutely.
is kind of a routine. I think
Should
these are
be.
the very
Absolutely.
strong key messages.
Yeah.
Thank you so much for
Thank you.
taking out time for your busy schedule, sir.
Thank you very much.
Thank you.
Appreciate. Thank you so much.
Thank you very much. It's been a pleasure. Thank you.
Been a pleasure. Thank you.
Okay.